So just to say hello, my name is Zlochower. I'm one of the neuroradiologists at Lenox Hill Hospital. And I'm here to talk to you about Introduction to Stroke Imaging. Okay. So I guess I've been told I have to start with a joke or a meme or something. So I know that I don't even know if these commercials exist anymore. This was like a big thing when I was like in med school and residency, these Dos Equis commercials, but you know, the most interesting man in the world who, unfortunately in this case, is experiencing a stroke. So, you know, something to always think about is it can happen to anyone and anywhere, even the most interesting man in the world. Okay. So what are we going to be talking about today? This is going to be a little bit more informational, kind of what we do with stroke in terms of imaging. So we're going to discuss some stroke basics and its impact, as well as I know there's this, you know, you have the virtual ORs and things like that, which are a lot more exciting than a virtual stroke code, but it's actually something that, you know, you'll see why it's relevant and how we handle it, and, you know, what it means as to the group and for everybody. And really, even at the stage of wherever you are, you know, understanding what the process is, what we do for imaging, and how the process for stroke is, it can actually be impactful for you, not just in the future, but for right now. Okay, so basics of stroke. So so what is a stroke? I should probably start with a very, you know, simple, just to make sure we're all on the same page. A stroke is essentially where there is an acute, what we call neurological event. So there's some acute event that happens that the concerns that there's underlying damage to the brain. So inadequate blood, you know, inadequate oxygenation of the brain. And what happens is the brain lives on oxygen. It doesn't live on it. Really, that's what it does, is it lives on oxygen. Anything needs oxygen to survive. And if it doesn't get the right blood supply in different forms, it's going to die. And that death is what we call a stroke. Infarction is the fancier term we use for it. So there's really the main one, which we're going to focus on, is something called an ischemic stroke. So when people talk about stroke, mostly they're talking about what we call ischemic stroke, where there's not sufficient blood supply to supply the brain and it dies. Other things that can happen is you can get hemorrhage. You can get a bleed. And what happens is that the bleed, you're not going to get blood supply to the brain there. And again, it can lead to death. But those are called hemorrhagic strokes. Those are not as common, and they're really a separate entity. I want to really focus on what we call ischemic stroke. So then there's something called a stroke code. What does that mean? A patient has an acute and neurological event, and they're worried, oh, does this patient have a stroke? And really, so the main thing here, there's this like mantra that everyone kind of lives on in neurology, neuroradiology, neurointerventional, anything, which is called this idea that time is brain. That basically, you know, the longer it takes to, you know, whether it's opening up a vessel to treat the stroke, the longer you take, the more neurons, brain cells die. So one of the things we want to do is do very rapid imaging. We want to go basically, you know, this patient, you know, is going to go to run through as quickly as possible so that we can assess and evaluate and possibly treat this patient without having too much damage done. And that's why a lot of these things are fast. We actually have time limits for how long it takes to the patient to get to a CT scan, how long it takes for them to do the CT scan, and how long it takes for us to interpret the CT scan. So that's that's how a time factor is. And then you also look for other causes that causing their symptoms, not just what we call an ischemic stroke. Could it be a bleed or tumors or other things? Okay. So there's this mnemonic that people use, which is very helpful. This is like helpful out in the community for the signs of stroke. So there's something called BFAST. So if there's balance issues, you know, loss of balance, blurry vision, face, that they have a facial droop, their arm, one arm or one leg becomes weak, or speech difficulty, then the T is time. Call the ambulance. This is patient you suspect has a stroke. So these are things that if you're seeing now in your regular life, just walking around in the city or wherever you are, not just like, you know, you're sitting here in a brain term lecture. So these are important things for in the community to recognize that these might be symptoms of a stroke, and therefore to get appropriate help. So basic just info, stroke is the 5th leading cause of death in the US. You know, every 40 seconds, every, you know, patient that suffers a stroke, every 4 minutes someone dies of it. There's almost 800,000 people have a stroke annually. Costs a huge, you know, this is from the CDC. You know, we see that there's huge amount of cost involved with it, $46 billion, and it's a leading cause of serious long-term disability. So this is a major issue. And so that's why it's not, you know, this isn't like a rare thing that we deal with that, you know, happens to be in some places. This is something that you see all the time, unfortunately. So it's important for us to understand it. Okay. So I talked about this mantra of time is brain. So there's this cool study that they did that basically they actually wanted to quantify that. So again, we're talking about ischemic stroke, inadequate blood supply to the brain, and that leads to cell death. So so we see it's almost like 2 million neurons a minute. They talk about, you know, there's the axon. So, you know, basically there's the long fibers that connect the brain to wherever it's going to. Let's say all the way down to the muscles in the toe. You know, it's just one huge big fiber. So, you know, talking about 7 miles of death, you know, destruction. And each hour that the stroke persists can be, you know, 3 years of aging. So it's like a major. So when we talk about time is brain, this is what we mean. Okay. I know there's a lot of things going in the chat. Actually, if, you know, if there's anything you want to stop me in the middle to bring up while we're going along, that's please.
Okay, Dr. Flores has answered some of this too, but
okay.
You can keep going, I think.
Okay, good. So those are the basics. So now we're going to talk about stroke imaging. So I think, to me, the way I break it down is that stroke imaging, when we have a patient who's on the table for a stroke code, there's 6 questions I want to think about. So number 1, is there blood? And we're going to use a non-contrast CT head, which we'll discuss what that means. Are there signs of an acute stroke already on the CT? Is there a blockage, a clot, what we call a thrombus, that is causing their symptoms and that can potentially be treated? And can you get to it? And we're going to use something called a CT angiography, which is, basically we'll talk about what that involves, but we use contrast dye to look at the vessels. And then we're going to use a little bit of a fancier technique called CT perfusion, which is a technique used to evaluate the brain in different ways. And we're looking for something called a core infarction, basically an area of dead tissue, and what was called Penumbra, tissue that's not dead, but may be treatable. And this is extremely important for treating strokes. And this is why, and we'll discuss what all these things mean. But I just want to give you an overview. If you can answer these 6 questions with our stroke code, we've basically done what we've needed to do, okay? So I'm gonna like to discuss this as a case study. So we're gonna go through a case. So we have a patient, 73-year-old female. She had this rapid onset of a right facial droop. So the right side of her face kind of became weak. So she was going like this, even though that's the left side of my face, I'll go like this. And then she had slurred speech and she had right arm weakness. So these are signs, you know, back to your be fast, you know, these are signs of an acute stroke. And because of her presentation, she got something called TPA, which is tissue plasminogen activator, which is basically, well, it's a clot busting drug that is given by the neurologist. And so because of that, her symptoms, and what we'll see on the CT head, which we'll discuss, she got this medication called TPA. Very important. Okay, so what do, right? You're walking around in New York City, in Manhattan, which is where I am right now. You're on the Upper East Side and you see this happening right in front of you. Call the ambulance. They get to the ER, they're gonna go directly to CT to get a CAT scan. Because again, what do we say? What's the mantra of stroke imaging? Time is brain. The longer we take to sit there and wait and this and that, you know, patient gets worse and worse and worse, and that's bad. So they're gonna go straight to CT as quickly as we can, right? All right, so now we've activated stroke code. And for those of us in the neuroradiology world, this is like, you know, okay, stop everything, we gotta deal with this. So what is involved in a stroke code? There are 3 components. A non-contrast, meaning we don't give any IV dye. We just do a CAT scan of the head. And for those who are involved with Dr. Promnick's lecture last week, you know, basically it's CT, just for short explanation, is basically a 3D X-ray. And we're doing that of the head, getting these images. We don't use IV dye. We then do CTA, where we give IV contrast dye to look at the vessels, the arteries in the neck and the brain. And then we're going to do something called CT perfusion. Okay, so non-contrast CT head. What is this? This is the first critical step to evaluating acute ischemic stroke. And we're looking for two things, basically. Two basic things. Are there signs of a bleed and a hemorrhage? And are there signs that the patient has already undergoing an acute stroke? There's two things we talk about there. There's something called the hyperdense, the bright vessel, which that indicates that there's a blockage. Doesn't mean that their brain tissue has died yet, but it just means that there's a blockage there, a thrombus. And then there's something called loss of gray white matter differentiation, which I'll show you an example of what that means, where basically the brain tissue, there's something called the gray matter, which is what we call the cortex. And then there's the white matter, which is where most of the neuron fibers travel through. And they should look different on the CT. If you don't see that distinction well, and then eventually if it becomes less bright, less what we call hypodense, less dense, then you're thinking it's almost becoming like water. So those are signs of an acute stroke, that part of the brain has a stroke already. And those are the things we look for on the non-contrast CT head. So why does this matter? Like, the patient's having a stroke. Who cares if there's a bleed up there? Who cares if they already have a stroke, right? Besides for information, why is it that we have this time pressure? We literally document, we spoke to someone within 10 minutes of when it happens. Why do we have it? Why does that matter? So it's because the first thing why that matters is something called TPA, that drug that I talked about, which is this tissue plasminogen activator. Plasminogen activator, this clot busting drug. So before 1995, basically, there wasn't a lot to do for patients who had stroke. Then there was this major trial which showed that you have patients who got this TPA within certain parameters, and those certain parameters are crucial, had better outcomes than if they didn't get it. And therefore, it's like a major, major effect that this drug had on helping patients, recover from strokes. And two things are critical for that. So there's a bunch of contraindications, reasons why you don't give it. Two things one is that they already have a head bleed. So this clot busting drug can lead to bleed. So if you already have a bleed, an intracranial bleed, then you can't give it. And two, if they already have a big stroke, what we call, so there's something called the territories, the different parts of the vessels supply different parts of the brain and they have different effects. If they've already have a big stroke, then the efficacy of the drug is not so great, and it can actually lead more likely to them to bleed. So the benefits don't outweigh the risks. The risks are actually greater. So in those cases, if they already have a big stroke, they're not going to give the drug. And if they already have a bleed, or if they have a bleed, they're not going to give the drug. And also there's a time pressure. They can only give it within 3 hours or 4.5 hours of symptom onset. That was the original study it's done. They can't give it 7, 10 hours later, potentially. So that's why the time crunch and why we have to tell them whether there's a bleed or not and whether there's a big stroke or not, okay? So let me just show you this example. This is a 95-year-old came in with altered mental status. So when I talk about, using the wrong cursor, right? So this is a non-contrast CT head. So this is a patient, this is their brain in the CAT scan. So, it's a little bit hard maybe in this picture to image, but this area here that I'm kind of outlining, this like gray, ribbon stuff, that's the gray matter. And it's harder to see, but there's some white matter. This patient has a lot of volume loss because they're older, 95. But if you see here, I'm going to make it almost shaped like a wedge or a pie slice, a big pie slice, right? You see it's not as bright as the rest of the brain, right? And it's very well kind of what we call demarcated. You can kind of cut it, make a pencil line through. This patient has already had a stroke. A large stroke. This is a very large stroke. So this is a patient where if they want to know it's just worthwhile to give TPA, it's probably not based on this image because they already have a very large stroke that's done. Unfortunately, this part of the brain had cell death, right? And so it's really not recoverable. And that's one of the crucial things we look for in these cases. This is another crucial thing we look for. This is a 73-year-old male, but slurred speech and right-sided weakness. And we look, before we talked about things being, so right, this is a normal, what we call density, color image of the brain. And this is low density, hypodensity. For bleeds, acute bleeds, it's hyper, high density. And we see here, there's a focal bleed here. It's called it's in the brain itself, brain parenchyma. So it's a parenchymal hemorrhage. And then here, which is actually not in the brain itself, it's actually in these areas around the brain that are called the cerebral sulci. That is what we call a subarachnoid hemorrhage. So this patient has an intracranial bleed. So again, you can't give them TPA because they have a bleed. So that's why this non-contrast, the CT head, this rapid thing is so important, because we can tell them right away that, no good. This is not what, a good case to do TPA. Okay, so now let's go to the case that we talked about. Again, there was a 73-year-old woman who had a right-sided weakness, slurred speech. And so if you look here, you don't see on this CT head any signs of where you're having hypodensity, when you have major loss of what we call the gray-white matter. So you can actually see here, this is a little bit gray. This isn't white, it's actually dark because we reversed it on CT. But basically, this is what we call this is the gray matter, the cortex, the white matter. We can see the difference between them well. So she doesn't have signs that she already has dead brain tissue. But if you can see a little subtle there, this is the vessel, what we call her middle cerebral artery, and it's bright. So she has what's sometimes referred to as the dense MCA, dense meaning bright, MCA, which indicates that we think that she has a clot, a thrombus there. Okay, so now then I'm just going to finish this part here. So CT head, the questions, right? What was our questions that we go to? Why do we get the CT head? Is there acute blood? So in our case, no, we don't see any signs of an acute blood. Are there signs of an acute stroke? Well, as far as the part of the loss of the gray-white matter, meaning the loss, the sign that there's already dead brain, we don't have any evidence on the CT head. But we do have evidence that they might have a thrombus, a blockage, which is crucial for them to know. Okay, I know if you want me to stop here to do questions or just keep going. But so we did step 1 on the stroke code. So the next step, after we finish our non-contrast CT head, is we're going to do a CTA head and neck, a CT angiography, where we're going to give contrast dye and we're going to look at the vessels in the brain and in the neck. Okay. And then we'll talk later about the CT perfusion. So again, what are we doing? What's the purpose of this CTA head and neck, right? What are we trying to figure out? So is there a clot, a blockage that can be treated? And we'll talk about another form of treatment, which is critical and valuable and radically change stroke treatment. And can you get to it? Which involves interesting questions. So in order to understand the importance of a CT angiography, you have to understand there's something called mechanical thrombectomy. So again, up until 1995, we didn't really have much. Then we had this clot buster drug, TPA. That's amazing. But it's not 100%. There are limitations. There's time limitations. Beyond a certain time period, they can't give it. So if a patient has a wake, for example, very common situation that comes up, patient went to sleep at 11 o'clock at night, okay, woke up the next morning, can't move the right side of the body. It's clearly having signs of a stroke. But the problem is you don't know when that happened. They woke up, let's say, 8 in the morning. Did that happen at 7:45 a.m. or did that happen at 12 a.m.? You don't know. And so in those cases, since we don't know the time, they can't get TPA. So that's one major drawback to TPA. Another thing is that there's some clots that just isn't going to be effective. We know that. And so therefore, we need a better way. There are other ways to treat them. So what you do is something called mechanical thrombectomy. Another thing that can be done is if you see that there's a blockage, they can actually go in and remove that clot. There's 2 different mechanisms, and lots of times they use both together. Something called aspiration, where it's literally sucking the clot back into a tube, a catheter. Another thing where it's something called a stent retriever, where it actually has like a stent which grabs onto the clot and brings it into the catheter, and they take the whole thing out. So they can actually mechanically that's why it's called mechanical, take out the clot and then restore the blood flow into that part of the brain. And this is shown to dramatically improve outcomes on patients. This is done effectively and can be used with patients who 6 hours out, 8 hours out, even up to 24 hours out from their onset. So where normally they can't get TPA, but they can still be treated with thrombectomy. And then I've seen this myself, seeing the patients who wake up next day, even way later, and actually had way dramatic improvement with this. Okay. Right? But what do you need to know for that? You need to know that there's a clot, right? Because if there's no clot that you can see that they can physically get to, then you can't do it. Okay. So what do you need to know is something called a large vessel occlusion, LVO. So you need a clot that can be retrieved. So what is considered what we call large vessels? So this is all talking about the arteries in your brain. And I'll show you what those arteries look like if you're kind of like, what are you talking about? I don't even know what the arteries are. I'll show you what they are and what we're talking about. They are something called the internal carotid artery, which is the big major supply artery into your brain, intracranial. It involves something called the middle cerebral artery, which is one of the main arteries into a large part of the things that affect motion, movement, and sensory in your brain. Something called the basilar artery, which is something involved in the back of the part of the brain, which gets to the brainstem, critical areas that you need for life. And then there's a question about some of the other vessels in the brain, anterior cerebral artery, posterior cerebral artery, those ones, whether they can really be treated. But these are the arteries that if there's a blockage, they can potentially treat them with this mechanical thrombectomy. So we have to tell them there's a block. That's our job. Okay. So what is this CTA that we're talking about? Okay. So a CT again is where we use this 3D X-ray to look at different parts of the body. We're going to do it over the neck and the head, and we're going to give IV contrast dye. And what we're going to do is we're going to time it that we get it that the dye makes that those vessels look bright on our CT, and those are going to be in the arteries, not the veins, the arteries in the brain and in the neck. Okay, and that's going to look to see if is there a block and where it's located, and can I get to it? Because you can do the way you get to it is something called a catheter. So they put a catheter typically in the groin, in the femoral artery in the groin. That catheter is a catheter system, so it's not just one catheter. That system's going to go up from the arteries in the groin all the way to your aorta, out through the heart, into the main arteries and there in the neck and the brain. So you got to get a catheter so it's endovascular. So it's all happening in the vessels in the arteries. And you got to be able to get to a blockage. So you have to know that there's a block there. And so there has to be a pathway. If there's a blockage in other places that they can't get to it, then they can't get to it. And is it too far, which is going to be a little bit beyond our scope of our discussion. Okay. So I think the important thing to understand is what is the anatomy that we're dealing with. So I'm just showing you a picture here. This is what we call the aortic arch. This is the aorta, the main blood vessel from the heart supplying everywhere, but including here in the brain, things that are going to go to the brain. This here is called the left subclavian artery. This is the left common carotid artery. This is the right common carotid artery, and you can see it partially the right. This is what's called the innominate artery. So these are the common carotid arteries. Those are the two major arteries that are going to supply the anterior, the front part of the brain, where things like movement, sensory is going to be. And this subclavian arteries are going to supply the vertebral arteries, which go to the back part, through the spine, into the back part of the brain. Is going to do things like involve like the brainstem and things involved in vision. So all critically important vessels. Okay, so now let's take one of the common carotid arteries. So now I'm going to do right. So I'm going to it's going to branch off. This is anterior, I mean the front part of the body, posterior, the back part of the body. That's the way you're looking. There's the external carotid arteries. We're not going to worry about those. Involve things in the neck and the face. That's not worried about. Then there's something called the internal carotid artery. Big major thing to talk about. This is the artery that's going to go all the way up to the brain. And you have two sides, right and left. Now I've gone. This is in the neck. This is going to be like, if you imagine, like kind of like kind of right below your jaw. that's where this is going to be. This is going to be like at the level right below your jaw. And if you kind of draw a line, continue imagining this vessel goes all the way up, and this is the end of this vessel. If this is the left side. So just a thing to clarify, in radiology, the left is the right and the right is the left. So when I talk about things on the left, I'm talking to the right side of the image. And I'm talking about things on the right, I'm talking about the left side of the image. So just so we're clear, this is the left. So this here is the left internal carotid artery. And this is where it's going to branch off. So this here, this part is called the middle cerebral artery. This is the anterior cerebral artery. So middle, anterior, internal, right? And this is almost makes like a T. This is terminus and it's making a T. So middle, anterior. And now on the right side, similar thing, right internal carotid artery, right middle cerebral artery, right anterior cerebral artery. And there's a connection between them called the anterior communicating artery. Okay, so that's what we call the anterior circulation, the things that go to the parts of the brain that control lots of things involved with movement and sensation. Now let's talk about what we call the posterior circulation, things in the back of your, going from the, in the back part of your neck all the way to the back part of your brain. So what are involved in that? Vertebral artery, vertebral artery. So these are coming from what we call the subclavians. They actually go through the vertebral, the vertebrae, right? Not literally through a hole in the vertebrae. So this is the left again, this is the right. This is what we call the basilar artery, critical artery. And it's going to supply, and this is going to go into this, which is the right posterior cerebral artery and the left posterior cerebral artery, okay? And this is the cap, the circle of Willis. This is the connection through the interior, and so this is a crucial area to look at. So this is, if you're looking, so before we were looking at the brain in different pictures, this is if I'm looking, slicing through here, kind of across what we call axial. And so this is a picture of that. And this is a connection, how your brain, the anterior, the front part of your brain circulation, and the posterior, the back part of your brain circulation connect with each other. And so this is the end of the internal carotid arteries. So here's the basilar artery. It's going to go, this is superior cerebellar, don't worry about that. Posterior cerebral artery, these are the posterior cerebral arteries. This is what we call the middle cerebral artery, anterior. Posterior communicating artery, so this is the connection between the arteries in the front and the back, critical. This is a connection between these two arteries here, the anterior cerebral arteries. Okay. All right. Any questions? I just want to, before I get too far ahead.
There were some, we are running a little short on time.
Okay, so I'll just go through the rest. I can maybe save it to the end if it's not anything that people can't even understand what I'm talking about.
Yes, fine. Go ahead.
Okay, so back to our case. So this is a different case, 73-year-old with right-sided weakness. So you can see here that there's a clot here, right? You see that the vessel is no longer being opacified in the left MCA. But the problem in that case is if you go up, if you remember, you're losing, this is where the ICA, internal carotid artery, should be in the neck, and you can't get there. So that's a major problem. So now in our case, back to the case that we were dealing with, so we have this bright thing here, and if it turns out, if you look, they actually do have a clot in that left MCA, middle cerebral artery. So they have a thrombus, an occlusion. So this is something that's potentially can be treated with a thrombectomy. And we actually look, they have a little, little disease there, but otherwise it's opus. They can get to it. So we've answered the two questions. Is there a clot? Yes. Can we get to it? Yes. Great. Let's move on. So I'm going to just kind of go briefly through CT perfusion just because I think we're running a little bit low. So we want to know is it too late? Has there been too much damage already done? And beyond what we can see early on the CT head. So is it too late, which is what was something we call a cord infarction? And is there something that we can actually save? So I'm going to talk about different parts of the brain. So when you have ischemia, which is decreased cerebral blood flow, which ultimately can lead to death of the brain tissue, the neurons, is there irreversible areas? It's gone. You can't do anything about it. That's what we call core infarction. Is there an area that is decreased that's potentially might die, but it may not and potentially salvageable? This is the goal. This is what we're trying to get to. Save this. And then there's other stuff that it's just going to get better on its own. This is just a visual representation. If you imagine that C, this part here is dead. Can't help it. This is the part that you can help, called penumbra. And this is the part that it'll get better on its own. So what we do is, basically, we're going to give IV contrast. We're going to have it go through the entire circulation. And what we're going to do is, over this part of the brain, we're going to go over, CT over and over and over and over again. And we're going to make all kinds of fancy calculations. I'm not going to get into what the calculations are. But basically, there's something called tissue factors and time factors. There's certain parameters involved with the blood flow and the blood volume. What those parameters tell you is that if they're decreased enough, means that part of the brain we're assuming is infarct, it's dead. You can't help it. However, there's another factor which is related to time. Is there delay? Is there too much time to take to get to that part of the brain? And that's going to relate to something called ischemia. Increased, not enough blood supply. That stuff may ultimately be dead tissue or may not be what we call penumbra. And that's the critical thing. What do I mean? I'm just going to show you an example so you can understand it. This is a software we call Rapid, which we use to kind of automate this. They're going to give you 3 important things. There's something called cerebral blood flow. That's what the CBF. If it's decreased enough, less than 30% of what should be normally, meaning it's not even 70, it's more than 70% lower, they're going to call it that's dead tissue, infarct. This is something called Tmax, time, elevated. That extra time means ischemia. It's going to take too long for the blood to get what it needs, for the brain to get the blood that it needs. The difference between them, this minus this, that volume minus this volume, is what we call penumbra, meaning potentially salvageable tissue. So you want, this is low, this is high, and this is the difference between them. That's the goal. So this is an example, which is not a good example in the sense that this is dead tissue, or we presume is dead tissue, but this is a pretty big number already. Even though it's much bigger on this side, so you have to see a big difference between them, 60, but it's pretty high number as it is. Our case, just to end this part off, this is the CBF less than 30%. This is that tells us the infarct volume, which you see 0. That's the best example, what we want. And this is the Tmax, the elevated time, meaning ischemia, meaning delay in getting the blood to the brain, to the parts that are needed, which is this part of the brain called the left MCA territory, which is a good number, meaning it's a high number, meaning that there is tissue at risk that if they don't do anything, that might eventually develop into stroke. And so therefore, by getting that clot out, you can save this part of the brain, which is critical parts involving speech and movement. So this is crucial. Okay, and this is actually the image from the Angio, which I'm not going to get into Angio, but basically you can see here, this is, they give IV contrast, they give IV dye, or it's not IV, it's actually in the artery. And you see this part of the vessel, this is the left MCA, you don't see contrast there because it's blocked. And then after they get the clot out, you can see now there's contrast there because they've removed it. Now they've restored blood flow to that crucial part of the brain. And that's the goal here, and that's what we're trying to get to. Okay. I think, yeah, this is it for my presentation. So if there are any questions, I know that we're running a little bit late and I apologize for that.
No, I think this was really interesting and people wanted to hear. Let me see. There were a couple questions. People were saying it was fascinating. Oh, this is something. So in terms of the contrast dye,
yes.
Someone asked how it can stay just restricted to the arterial compartment.
So it doesn't. That's actually true. We don't get it. So it's a timing thing. So we know within a certain time period and we can track it. And actually, usually by the time, practically speaking, we get it both in the arteries and the veins. But we want to make sure we actually time it. We do like a little test bolus, like a little test run to see, oh, at 10 seconds, at 15 seconds, it's going to be there. Perfect. And we're going to do it. And we're going to do our CT then. And we're going to actually see that the vessel's then. If we get it too late, we miss it. And then we're just like, oh, I'm sorry, it's too late. We can't evaluate it.
Oh, interesting. That's very cool.
I think I saw a question someone had about how long do you have for thrombectomies? I mean, quicker the better is the answer. But yes.
Is that stressful for you? Like you were under such a time crunch? Is that like ever stressful? How do you handle that?
Yeah, so I just to give you a little background, I did in my fellowship, I did a neuroradiology fellowship. My fellowship actually is kind of not very common, normally it's just done by, let's say, neurosurgery, sometimes neurology. Rarely it's done by neuroradiology. We happen to be the ones who did them sometimes. So I was actually involved in these cases. And yes, it's actually something where literally you're like, come on, let's get the patient on the table. You know, you're not sitting around like, hemming and hawing. This is like, come on. They actually have time limits to when we actually puncture the arteries in the groin. Like all these things are very like, you know, but the main thing is you have to be safe for anything else. And you got to get consent. You got to make sure you're legally allowed to do it and all these things.
Yeah.
Why can't you give TPA if you don't have time? Great question, because the time, you know, part of it has to do with the studies were done within certain time periods. So if you're going beyond the time period, it's like you're kind of getting beyond where you have legal safety for doing it. And also we know that longer it is, it's just not as effective. So if you don't know when the time was, then you're like taking a gamble, like if it was 10 hours ago versus 10 minutes ago. And so that's why if they don't know the time, they just can't give TPA.
Someone asked, can we bypass the blocked artery instead of removing the blockade?
Yes, but you know that involves a big surgery and the time thing. So it is a lot easier if we can remove the blockage directly as opposed to doing it through. But there are times, as we do it here, which doesn't happen in a lot of other hospitals. There are times where you have to do this kind of bypass, literally a bypass. So yes, there are cases that you can do that, but better to do it this way. It's right there, easier, less morbidity for the patient to do it that way.
Okay, very cool.
TIAs typically do not show up on a CT scan because they're usually not caused by an actual blockage and dead tissue. They're actually like a temporary thing, but they can be a sign that the patient might be at risk of having more permanent stroke.